So, because of time shortage, I won't go into the background of what is PCOS. You all know it is the commonest endocrinopathy of women in reproductive age. What have I done? Okay, it's ready. All right. And it's mainly composed from the abnormalities of anovulation, polycystic ovarian morphology, androgen excess, and metabolic derangements, which are multiple and can be present in some phenotypes of PCOS, and in some others are not there. As we said, it's the commonest endocrinopathy. The etiological background of PCOS, you can see it in this picture, and you can see the three main hypotheses, which is the neuroendocrine hypothesis, suggesting that neuroregulation is disturbed in pathophysiology of PCOS, with GnRH pulsatility to be disturbed and usually increased. The insulin hypothesis, which plays a central role causing insulin resistance, which then secondarily hyperinsulinemia acts on the ovary, and you see the third hypothesis, ovarian hypothesis, ovary is stimulated by insulin and causing hyperandrogenemia, and insulin contributes to LH, early luteinization, and therefore anovulation. And what is more important, to go into the main topic of this presentation, is to realize before we analyze any drug-induced PCOS, we have to distinguish between PCO morphology and the syndrome. We have to distinguish between the separate components of polycystic ovarian syndrome, which can be caused by different medications, and to the whole picture of PCOS, which can be induced by certain medications, as we're going to talk about. So PCO morphology is an ultrasound diagnosis and has certain characteristics which may be present or may not be present in order to make the diagnosis of polycystic ovarian syndrome. Now, look at this picture, and I think it's very, very, very characteristic. What do we have here? We have the drug, which can act on different levels of the pathophysiology of PCOS, and each one of them can contribute to alter the phenotype of PCOS. In other words, I'm going to show you, we have medications which can cause obesity, and you're going to listen to that about this topic tomorrow morning by Dr. Migdalis. Medications which are inducing obesity. Obesity is the situation which can reveal PCOS or can aggravate the whole phenotype of PCOS. This is not what we are talking about as a drug-induced PCOS. It's not a matter of stimulating one aspect or one abnormal parameter of PCOS to call that this drug is inducing PCOS. PCOS is a syndrome, and it has to have certain characteristic or certain abnormalities in the pathophysiological mechanisms in order to say that this PCOS, this syndrome, is induced by the presence of certain medications. Therefore, we have here some medications can cause insulin resistance, and through this mechanism can have a picture of metabolic syndrome, or can cause some abnormalities in the hypothalamic pituitary axis, or can stimulate ovarian tissue, like, for example, anabolics, and present the picture of hyperandrogenemia. But this is not the syndrome. Okay, what we would like to look as a drug-induced PCOS, it's here. It's a situation like here, which would stimulate hypothalamus, would stimulate the ovary for overproduction of androgens, and also would affect the metabolism of androgens acting in the liver, altering the P450 enzymes, increasing the catabolism preventing the catabolism of androgens and leading up to increase of them, or affecting SHBG and reducing SHBG, therefore in an indirect way increasing androgens. But what would we like? We would like to have all this together caused by a drug, not just one by one. Then let's look at the next slide. Could that be done by a medication? That's why I have left out all medications which can cause obesity, psychotropics, or medications which can cause anabolic steroids. You're going to listen about all this the next 2 days by experts. So I'm leaving this out, and I'm focusing to medications which can cause globally this multifaceted syndrome of polycystic ovarian syndrome. Now, look at this. A medication which could be involved in all these 3 levels. And this is valproate, which is a valproic acid, short chain fatty acid, which is a very specific and a very efficient medication for epilepsy. And you know that many women are on this medication. So this medication has been shown to act on hypothalamus and in a way increases the appetite, not the pulsatility, from what we know so far. Also has a direct action on theca cells of the ovarian tissue, stimulating theca cells and increasing directly the production of androgens from the theca cells of the ovary. Now, the other thing is what a valproate can do is also activates P450, inhibits P450, and via that mechanism increases or decreases the catabolism of androgens, and therefore increasing the levels of androgens. So here we have a medication which can do all that, but cannot alter the pulsatility of GnRH from what we know. Could that be a situation in which we could have this as well in conditions like PCOS? Here it is. Here is the valproate acting on several areas, even acting here by decreasing aromatase activity and preventing testosterone to estrogens, therefore even via this way increases the androgens. But we don't have anything about this. What's happening to GnRH pulsatility? Well, what is interesting here is that we said that valproate are given for women who are suffering from epilepsy. Okay? Let's look at this. Here could be a condition which affects the pulsatility of GnRH and could coexist with valproate treatment. The answer is yes. Here, temporal lobe epilepsy, involving temporal lobe epilepsy, has the ability to activate GnRH pulsatility, and look at this here, via this way increases the pulsatility, and this is in favor of LH, as it happens in PCOS. So therefore we could say in situations where we are giving valproate, which affects many aspects of polycystic ovarian syndrome phenotype, additionally the condition we are targeting with valproate is here, and by itself this condition can contribute to pathophysiology of PCOS, to make complete the whole pathophysiological background abnormalities of PCOS. It has been said even on clinical grounds that women with epilepsy have more common polycystic ovarian syndrome compared to women, as you know, in the general population. And to conclude, we have here that valproate can contribute and can induce polycystic ovarian syndrome as a whole. The question comes, if we withdraw the medication, is this reversible? and data are showing here that girls who remain on valproate, they continue to have the picture of polycystic ovarian syndrome up to 60%, as compared to 5.5%, which are girls who had been on valproate, and valproate has been stopped. So this is another indication to support what we consider as drug-induced endocrinopathy, and specifically drug-induced PCOS. And to conclude, we try to approach drug-induced PCOS, which is a complicated clinical picture, has several aspects in the phenotype, but we are not looking for a single component of PCOS and then to call that it's a drug-induced PCOS. What we're looking at more global picture of PCOS, and sometimes there is a possibility that PCOS is underlying, and some medications or some situations can reveal it. And this is the PCOS phenotype, which can be present, revealed in susceptible individuals. And there are situations, as we said, like valproate, which can induce the whole syndrome of PCOS in a situation like epilepsy, where we have a deranged axis hypothalamic pituitary pulsatility of GN rates. Thank you for your attention.
Thank you.